Just wanted to welcome everyone and thank you for joining us. For those of you who I've not had the pleasure of meeting, my name is Megan Shu. I'm an orthopedic oncologist at the University of Iowa. And this webinar is brought to the membership by the MSTS Education Committee. A recording of this will be available in the education section of our website under webinars. We have several learning objectives today to practice live cutting guide planning sessions with a panel of 3 of our expert musculoskeletal oncologists with the cases that highlight a variety of resection and reconstruction choices you may face in your own practice. We also would like to learn some common pitfalls and expert tips and tricks for pre-op planning, as well as some best construct ideas based on resection type and as well as the soft tissue considerations. And so the purpose of this webinar is to discuss the custom cutting guide design process and implementation specifically for pelvic sarcoma resection and reconstruction. And the MSTS and members of this panel do not have financial disclosures regarding the use of any certain companies. Vendor choice is a personal choice based on what I have the most experience with and does not reflect the endorsement of the MSTS or our panelists. And with that being said, I have the honor of introducing our panelists today. So we are joined by Dr. Patrick Lynn from MD Anderson in Houston, Texas, as well as Dr. Krista Goulding, joining us from the Mayo Clinic in Phoenix, Arizona, and Dr. Jesse Roberts from the University of Washington in Seattle. We also have our Oncos engineering team, Chris, Deanna, and Kelsey here, who will help guide some of the live planning sessions for this call. So thank you so much to our panelists and engineers for sharing their time and expertise. They have put a great deal of time and effort into organizing this webinar, which I hope you'll find unique and helpful for your practice. And I also wanted to acknowledge Carrie Mink for her help in organizing and facilitating this webinar as well. The general structure will involve a case presentation, and then a live engineering session that simulates what you might experience if you were designing your own cutting guide. We'll have a case conclusion and then 1 to 2 questions per case. There will be time at the end of the Q&A for more questions from the chat. So I will be monitoring that throughout the webinar. And then without further ado, let's get to the good stuff. We can start our cases. Thanks for joining us.
Okay, I guess I'm on.
Yes.
All right. Well, thank you, Dr. Shu, and thank you, MSTS, for the opportunity. I'm Patrick Lynn at MD Anderson. I'm going to share my slides. Can you see that?
Yes, we can.
All right, great. Well, I'd like to share with you today a recent case we did, somewhat unusual. It's an intra-articular pelvicostomy for a sarcoma. Right. So this case involves a 69-year-old man with a solitary fibrous tumor, which was picked up on an X-ray with subtle findings near the acetabulum and ischium. The biopsy showed spindle cells with typical staghorn vessels and a characteristic fusion between the NAB2 and STAT6 gene, which clinched the diagnosis. The MRI shows a large mass abutting the rectum in the ischiorectal fossa and involvement of the posterior aspect of the acetabulum posterior column. You can see here at the yellow arrow where the tumor approaches the subchondral bone of the acetabulum. And again, on the sagittal and coronal CT views, you see the bone involvement. So our treatment plan involved no chemotherapy since there was no metastasis seen. We did treat the patient with preoperative radiation, 50 gray over 5 weeks. And then our plan was to do surgical resection with custom cutting guides and reconstruction with a custom pelvic implant. And so at this point, I'm going to stop sharing.
Okay. Is everyone able to see my screen?
Yes.
Okay, perfect. Alrighty. So, for Dr. Lynn's case, the first thing that we started off by doing was bringing in the segmentation from both the CT scan as well as the MRI that we had in this case. We combine those two together and then we review with him, which is currently shown in magenta here, what we have segmented out as tumor. We check in to make sure that this is what he is expecting to see based on his understanding of the imaging. In this case, it was. He did want to consider a 1 centimeter margin here. And so that's what you're going to see in yellow. The margin here is going to be one of the main drivers of where we're going to go ahead and place the cut planes. The placement and angles of the planes are guided by the margin, the exposure, overall surgeon preference, and additionally the soft tissue structures that could potentially be in the way. And so we ended up landing on this resection plan here, which was a periacetabular plan, and then the superior most cut plane was exiting right around the sciatic notch. However, we were mindful and trying to avoid the sacrum here. So we're getting close, but not cutting into the joint there. And then there is a ischial cut as well. And then,
Well, could I interject, Deanna?
absolutely. Go ahead, Dr. Lynn.
Which on the segmentation portion, part of the call, I find that to be a critical stage because typically what I like to do is to look at what you have created in terms of the segmentation with an MRI that I have on my computer screen to make sure that that matches what I am expecting to see. And there is definitely an art to that, but I just wanted to bring that out.
Yeah, definitely. That makes perfect sense. Yeah, we always try and start off these planning calls by making sure that it was going to be in line with what you were expecting to see, since that's going to be the real guiding principle to everything that we're planning out. So, totally makes sense to me. This is what we ended up coming up with in terms of the resection guide, the superior resection guide anyway. So anytime that we can, we try to register on at least 2, if not 3 unique anatomic landmarks. And so here you can kind of see that we have a hook that's kind of registering right below the AIIS. We have an additional hook that is coming slightly into the sciatic notch here. There is some offset that we incorporated in the acetabulum to be mindful of any cartilage or soft tissue that's in the way there. And then one final touchdown point that's sitting right on the pubis there, or right on the pubic root rather. So this is what the resection guide looked like. Moving forward, we can go ahead and get into how we went about the implant design, unless you had anything else to add at this point, Dr. Lynn.
Well, there were actually 2 cutting guides. You're showing the slimline version here, but there was also
There's
another
also
one
that inferior one, yeah.
that included the ischial cut as one connected cutting guide. And I'll show you a little bit of that in my next portion.
There you go.
Yep. Right.
Yeah, this one,
But what I received was both guides for the case, and that's often what happens is that we have not just one, but uh, 2 sets of slightly different guides, depending what would work better.
mhm. Yeah, makes total sense. And I know, of course, that you and Chris had discussed this cut, with just given how distal it is, it being relatively difficult in terms of the actual design of the guide. And so that's why the majority of it is registering on the bone removed rather than the bone remaining like we normally would and try to do. But just given how far distal it was, we ended up having to do something like this. So that's where we landed on the cutting guide. We can go ahead and start talking about how we went about designing the implant. Let me just turn a couple of things off here. Got this. Okay. So then from here, what we did is brought in a cup. Since, we are trying to keep the anterior column intact here, there were a couple of considerations. So we brought in a 54-65 inner and outer diameter cup in this instance, just trying to be mindful that we want to stay at the native hip center, but also want to not have to incorporate a ton of additional bone preparation or reaming. And so this size seemed to be appropriate where the ream would only be a couple of millimeters worth of bone that was going to be removed. So that's what you can see here in red. And so once we had this, we were able to start talking about fixation now that we have the cup placement locked in here. We were also set to 45-20 inclination and inversion in case anybody was curious about that. But once we have the cup placement in, then we can start talking about fixation. And so one of the ways that we start off, taking a look at the quality of the bone remaining is we go ahead and we turn a thickness map of the bone on, which is what I'm showing here. And so I set it to, this patient seems to have some pretty decent bone quality, so I turned up the scale a little bit to about 2 centimeters. But anything that you're seeing in gray would be coming in at about 2 centimeters thick or so or more. And then from red down to blue, we go from 2 centimeters down to 0. So ideally, we try and aim all of our screws within the gray regions that are shown in the thickness map here, and that kind of guides the initial placement, in addition to, exposure and what would be ideal trajectories. So in this case, what we went ahead and did was aimed a handful of screws, 2 of them going into the posterior column that would be going through the cup there. We also have this cluster of iliac flange screws that were also placed primarily in this nice thicker bone that you're seeing right above the cup here. We also have 1 cup screw going in the direction of the superior pubic ramus, and then 1 small flange screw that was placed just outside the cup right around the pubic root here. From here, we were able to take these design inputs offline and be able to go ahead and design the implant. And so this is the design that we ended up landing on for this case. And I will hand the mic back over to Dr. Lin if you wanted to talk more about this while I kind of rotate around for you.
One last comment is that for a lot of my cases, I do not try to connect to the ischium if I think it's going to be too difficult, because oftentimes I find that that may just increase the risk for complications at that region. People do okay without that ischial component, so we left that out in this case.
Makes sense. All right. Dr. Lin, do you have any additional slides?
Oh yeah, I have
Okay.
my back's set. I'll try to run through them quickly.
Thank you, Deanna.
Yeah, no problem.
We can see it.
All right, so I'm showing the original surgical plan with the osteotomy shown with the red arrows. You can see those. And the more ambitious cutting guide involving all the cuts with 1 connected guide there. Couple things to reinforce. These are the hooks that Deanna talked about. Important one at the AIIS and at the sciatic notch that really anchors our implants. The acetabular contour matching is also important in terms of setting the guide properly. Then pinholes. One other thing to bring out is that I use uncaptured cutting planes since I find that if you have a captured cutting plane, it may be more accurate, but it is very difficult to work with. This is maybe more open to operator error if the saw blade doesn't sit flat completely on the cutting guide, but it does allow for more movement and freedom. This is our surgical approach. My preferred approach is a straight lateral. And exposure, you can see the gluteus medius opened up. And the main intraoperative finding I wanted to share is that this is not easy. What you can see here, buried very deep in the middle, is the cutting guide. This is our resident pulling very hard and water skiing on the bone hook. The bone, the greater trochanter femur, gluteus medius, gluteus maximus, those are really fighting us. This, what I like to use, is an Olea bone scalpel. And the main reason is that it has a very deep blade that can reach very far down. So a close-up of our cutting guide in place with the bone scalpel here. And you can kind of appreciate from this how difficult it would be to have the large cutting guide. We could not get that seated, so what we ended up using is the small one. And I just did a freehand ischial cut here. We also had to cut the sacrum because it involved the sacrum, and that was a freehand cut too. But I was not confident that we'd be able to make this cut accurately, and therefore our implant did not include an ischial arm to connect to the lower part of the bone. But part of the case we do with navigation and intraoperative CT, which confirms placement of our long screws in the intended position, and this is the rendered implant from the CT scan showing satisfactory position. And so, in summary, an intra-articular ostomy is very challenging, but it does offer certain advantages. I don't have time to go into that now. People's gait can be quite good with this. The greater trochanter femur, gluteus medius, gluteus maximus, they are very difficult to retract and get out of the way, and so that limits what we can do with cutting guides. These have to be as low profile as possible to work. The Olea bone scalpel is a very useful tool to reach deep, and there is not, as I've found in my own patients, a strict need to attach to or reconstruct the ischium. This allows for a little bit of wiggle room and a little bit more forgiveness in placing the implant. So that, I think, is it.
Wonderful. Thank you so much, Dr. Lin. I did want to encourage anyone in the audience to go ahead and use the question and answer function or post questions in the chat as we're going. There weren't any received so far for this, so I think in the interest of time, we can continue with the next case, but I did love hearing, this is what we want to see. We want to see the cutting guides, how they're designed, but then also how they're implemented and the challenges with the soft tissue and the local anatomy, because I think that's where a lot of frustration can come in for surgeons who have designed the perfect cutting guide and implant and then are maybe running into some of those problems. So learning about the forgiving nature of maybe considering an uncaptured guide or having those smaller low profile cutting guides as well as the bone scalpel are really helpful tips for us. So thank you very much.
Quick
And
question for Patrick. How long is that bone scalpel? I've used the bone scalpel before, but I've always felt limited, and maybe I don't have the right one. What's the
Right,
maximum length?
our original bone scalpel, which I imagine is what you're using, has a relatively short blade. The Olea that we have, I think we have 140 millimeter long blades, which sound long, but even those aren't quite long enough. You can't have a long enough blade on these. They are also much more aggressive than the bone scalpel that goes by that name. Um, so, yeah.
Got it. Well, that's a great segue to my talk. So I'll just jump right in if that's okay. And you guys just let me know if you can see the screen there.
we can see it. It looks
Okay,
good.
that's perfect. I'm going to flip my approach a little bit and give a little bit of upfront tips and tricks up front, and then we'll go to the reconstruction afterwards. So, you know, as we can see with the planning of these cases, and Dr. Lin gave such an elegant talk that makes you feel as though this was probably a very easy case, and these cases go on for many hours, and they're extremely challenging. They're anatomically complex. There's limited visibility, as we saw there. There's proximity of contiguous organs that we're worried about. And then there's really significant variability. I love the look of that cut, right through the center of the acetabulum. The case that I'm going to focus on today is also an extra-articular resection. But it's unique in that it was a proximal femoral resection with an en-bloc resection of the acetabulum. And so we'll look at, what are some considerations there when having lesion that's really involving quite a bit of the femur, and how to approach the acetabulum. Obviously, we know these have high rates of complications, but we know that these implants have really changed the nature of the reconstructions that we can accomplish, and many of these implants are really lasting for long periods of time. So it's a really exciting time to be an orthopedic oncologist, in my opinion. Initially, when I did my fellowship back with Chris Beauchamp at Mayo Clinic in Arizona, which is where I currently am working, we would 3D print in the back hallway. And then my job would be to chip off all the extra support structures, and we would soak it for 48 hours. And it was super helpful to have this 3D model to really mentally visualize the problem. But then it became even more useful to have that model to plan the resection and reconstruction. And so now we've got materials that we can sterilize, that you can hold in your hand and move around in a 3D way as you're doing these reconstructions, which I find particularly helpful. This is not the case that I'll discuss, but I saw this fellow last week. He's 10 years following the first implant from this company here, from Oncos actually, and he's doing mountain biking like 3 hours several times a week, and he's been probably our most successful patient. And I think one of the reasons that we, have really moved towards doing a lot of these reconstructions where it's appropriate. So these are some of the initial prototypes. The one on the left there, it was actually sort of a rendering with plaster that Chris Beauchamp kind of created and handed to the engineers and said, I need something like this. I feel like I've found what the solution is going to be for these acetabular components. And if you look kind of moving to, this is kind of a more modern implant, which is a little more lower profile, but just generally speaking, the design principle has remained pretty similar in our hands, which is fixation really to the remaining ilium only and a monoflange support pillar. I'm not typically reconstructing the pelvic ring. I have on several occasions, and I'm not sure that it makes a huge difference, but that's certainly controversial. You can see in the bottom right image there, we're trying to make that force vector directed towards the center of gravity to really apply bone and force through that area to try to get that implant to heal and to stay healed. And then, as Deanna mentioned, we're trying to recreate that anatomic hip center to really give the patient an equal limb length, and to get them as functional as possible. We have moved at our place. We've hired a biomedical engineer, Jose, excuse me, who has literally changed my life, I feel like. So he actually he 3D prints these models for us as we're in the kind of initial planning phases, so we can hold it in our hand and not just do a virtual planning session. And he segments the images with our musculoskeletal radiologist, which and we review that as well before it's actually sent to the company. And I think that gives us a lot of feeling of trust in where the tumor is and where we feel comfortable in placing the margin, which is obviously crucial. Manufacturing time is variable for these implants, but is on the order of about 5 weeks right now. Cutting jigs alone you can get, in about 2 weeks. The surgical approach is completely dependent on where the tumor is, what you need to take out. I like an extended iliofemoral approach. I carefully handle that T-junction, the triangle of doom, so to speak, in that middle that oftentimes has wound-related problems. And I do try to leave a skin bridge where possible, or curve the incision to avoid a T junction. I'll typically take down the abductor mechanism to expose the outer table, and then where necessary, do a classic trochanteric osteotomy to flip it up. And it seems like a really big approach, but it works great. You just have perfect exposure. And I really haven't had too many problems with healing of the classic trochanteric osteotomy, although I have had to take out some wires over the course of the year, including this fellow who's mountain biking, but he seemed to get back on his bike and have no problems with that. You really need a perfect fit of the guide on the outer table, and you do need to bone graft that implant as you're putting it in. The area of these 3D printed guides is about 4 millimeters, and the closest that I feel comfortable getting is around 8 millimeters. Guide wire location is, depends on where exactly you're placing the implant. I like 4, and I like also one where if you're doing a 2-step or a 3-step, I like one right where the 2 planes meet, and I think that facilitates the osteotomy. As we heard in Dr. Lynn's talk, the hooks and the anchor points need to be around reproducible areas where you can get a guide that sort of curves around and sits nicely. Because the worst thing, and I have had this happen, is putting an implant in there and having it shift around and then be worried intraoperatively of whether you're going to end up with a positive margin because it doesn't sit appropriately. You can see that guide there on the bottom. That was, say, 7-8 years ago. We had one that was very high profile like that, and we've really been able to kind of bring that down over the years. The image on the top right there is not my case, but I think these implants sort of call into question, what's the limit of what we can do. I personally feel that having posterior column and having a flat, having a cut where there's bone implant, a nice bone implant interface as opposed to fixing into the sacrum is safer. Certainly in our hands, it's worked better, and I tend to favor a step cut to really, direct the force up into that osteotomy site. Typically, we'll put 2 screws in the posterior column, 1 in the anterior column. Might consider soft tissue attachments. I've done this for a few cases. I haven't found them to be extremely helpful unless I'm putting a Gore-Tex mesh or something like that, which would be a consideration for the case I'm about to discuss if you're trying to reattach implants. But of course, the infection risk does go up with this. The porous surface we typically place on the outer table to try to get the abductors to heal back down with the extended iliofemoral approach. And then, of course, at the bone implant interface, but keep it smooth on the inside to avoid any issues with organs. And this is just a quick shot of another 22-year-old female with Ollier's disease and a low-grade chondrosarcoma who had a reconstruction and a nice result. And she's actually working as a ortho scrub tech, which is very cool. As I mentioned, closing the pelvic ring is controversial. The hip center location, I don't think is controversial. I personally like to place it in its native position. And then strategies to mitigate risks of certain complications like dislocation are to use a dual mobility construct, and I'll use that in almost every patient, or move to constrained if there's further instability, like the case I'm about to mention. We all know that the risks of infection are there, but what we have seen is that overall implant survival is actually looking really good for these implants, and it's exciting. What's horrible is taking them out, and this is a case that I had. This fellow had this implant. My partner put it in, and this guy came in with many other plates and allografts and such, and he'd had radiation. And the implant went in after many years after his initial diagnosis, and he, surviving that diagnosis of sarcoma, and he had a great result with this implant. Unfortunately, it got infected, and despite multiple surgeries to try to save it, we were unable to. So I vividly remember taking this out, and I remember how difficult it was with the curvature of that large flange there to try to get in and to remove it, because it was so well fixed to bone. And you can see the result there with, pretty significant amount of bone loss. And he did end up with a pretty big leg length discrepancy. And interestingly, he said, I know that it had to come out and I had to go through additional surgeries, but I'd go back and do it again for the amazing function I had for those 8 years. So it's interesting. I think patients are different, and but these implants are very exciting. So I'll just move quickly to this case in the interest of time. This is a 45-year-old male patient who presented with a grade 2 chondrosarcoma. You can see his radiographs there with this lesion located in the proximal femur extending up from the diaphysis up into the femoral neck region. And on further look, you can see the intra-articular involvement here. He did not have metastatic disease. The other staging studies were all negative. And so you can see here the reconstruction that we ended up doing, which with a very low profile custom cutting jig. This was actually a more posterior exposure, and obviously had to leave his trochanter on. And you can see the reconstruction there with a very low profile guide. And so I'm going to stop my sharing, and then we can hopefully go to look at the planning. There we go. Does that give you your screen back?
Yes, we can see Kelsey's screen now.
Okay, perfect. Thank you, Dr. Goulding. So as we were discussing, I've got that patient pulled up here. You can see, similar to the workflow that we discussed for the prior case with Dr. Lin, we start off just showing the segmented anatomy based on the CT scan and the MRI if available. You can see here that the tumor was mostly involving the femur, and it wasn't involving the hemipelvis, as you can see, but we were doing an en bloc resection. So we started off by placing some planes here as shown. So you can see we weren't creating a full discontinuity here. We're saving some of the posterior column. I'll hide the femur real quick so we can see a little bit better. But taking the entire acetabulum, coming underneath the AIIS and then through the pubic ramus as well. And then following that resection, we had the guides to help with that resection as well. Sort of similar layout here. We were using the landmarks such as the AIIS and ASIS, and then the curve of the posterior column and down around the ischial tuberosity. And then we didn't have a combined guide in this case, but we did have a separate guide here for the pubic ramus as well. And then once those resections are made with the guides, I can just hide all of that, and I can show you, again, we pop in a cup. In this case, we had used a 66 outer diameter cup. It was just big enough to allow for the cup to fit within the resection plan without requiring a ream as we did in Dr. Lin's case, but then also maximizing the inner diameter for your liner options down the road. Then placing some screws, you can see, let me turn the bone on here, the color map as well. In this case, we used a 15mm thickness map to really show where we could get the best fixation. I think Dr. Goulding had mentioned her plan often includes a couple of posterior column screws through the cup, as well as one through the anterior column kind of gluteal pillar. So we had incorporated that in this plan as well as a decently sized iliac flange and some cup screws into the ischium. We did also end up reconstructing back to the pubic ramus, just not with screws. You can see in our implant design here, we had more of like a biologic fixation with our porous interface with the implant and the bone resected. And then you could also see on a number of the implants, and in this plan as well, we had the external porous on the outer table for any ingrowth there as well.
I just want to point out that little step cut there anteriorly, just below or just posterior to the AIIS. And I always put that in now because I need to be able to get in a little osteotome. If it does get infected and you're trying to get it out, I find that that's a nice little window to be able to get in and around the implant. I probably would, this was done back in, I think, 2021, and I think I would probably bring the flange down maybe even a little more these days, um, but I liked this reconstruction. I'm not sure if nowadays if I'd put a screw into the anterior column or not. I still, I'm on the fence about whether or not that is necessary. I think when there's a big void, then it probably doesn't make a huge difference. And, just like a revision hip that you're hanging off of the ilium, probably these implants do well. And I have been monitoring my patients for SI joint issues. I do have one gentleman who has some widening of the SI joint with some pain without a reconstruction of the ring. But not everybody has that same complaint. What I like about this case was, was the preservation of that posterior column. I did put a constrained liner in this fellow because he was very unstable after resection of the proximal femur. Luckily, I didn't have any issues with instability. And he went on to he was quite an active guy. And I think he was previously sort of a marathoner and loved to bike. And he went back to competing in bike racing. And I think he placed in like the top third for his age group at the age of 49. Unfortunately, he did develop metastatic disease, but he did quite well from a functional perspective.
That's an amazing functional result. And thank you, Kelsey, for running through that. Dr. Goulding, did you have additional slides that you'd like to share?
Nope, I think that's great. I'll be happy to entertain any questions.
Wonderful. So we did have a question from the chat, kind of in general, what surgical position do each panelist prefer, supine, lateral, and how does that change your planning for these cutting guides?
I think it depends on where the tumor is. And as you saw in Dr. Lynn's case, and even the case that I presented, you can get access through a straight posterior approach, in which case, I think a floppy lateral position is best. But even when doing an extended iliofemoral, you really need to be able to access the front and the back. So for cases where I'm, have a larger tumor that I'm resecting, I'll position them very floppy lateral so that I can get all the way posterior and all the way anterior to the midline and beyond, especially if there's a large soft tissue mass. And I do think that the trochanteric osteotomy helps because it really just gives access to everything. But I haven't done any sort of purely supine, except the, like a P3 resection. I'll do those typically up in lithotomy with sort of a free draped leg.
And another question was for that superior ramus cutting guide. What was the registration for that? It looked like a free piece.
Yeah, I don't know, Deanna, did you have, or Kelsey, did you have a picture of that? I think it was freehand. I've tried all sorts of things with little handheld ones and, with the sort of beam that comes over the top. Sometimes I find that the soft tissues get in the way because although the mass is a certain size, there's a lot of muscle on top, it sometimes doesn't fit well. So I've kind of, I'll usually have a freehand jig that I can put on there, but it's extremely difficult to position it on a very tubular superior pubic ramus. And I think also just access to the ischium is difficult. So I will tend to do those. I've been doing those more freehand lately, although I do get the guides, in case it is easy to place, but haven't found them to be that useful.
Okay. And there's another question for Dr. Goulding from our chat in regard to the chondrosarcoma. Why a compress for the proximal femur compared to a cemented stem in one of the slides that you had shown?
I think both are equally good options, and frankly, I use cemented stems probably more commonly than I do the compress. I think in this gentleman, he was extremely fit, very active, and I was hoping to get biologic fixation, and I did think he would, sort of outlive I was hoping he would outlive the implant, and so I thought it was a pretty interesting case to get biologic fixation on both sides, but I was happy that he didn't fail. I think had he had maybe a more aggressive tumor with a higher risk of metastasis, at least from a prognostication standpoint that I may have selected a stem cemented implant.
Wonderful. Thank you very much for your questions and answers. In the interest of time, we'll move on to Dr. Roberts' talk, and we'll have time for more questions at the end as well. Please continue to put those great questions in the chat.
All right. So I'll jump in with something a little bit different. We're not going to jump to the design process since we've seen that twice, but I'll kind of touch on some of the nuances. I think one thing that is kind of ringing in my head as we go through this was something that I actually heard Dr. Raskin say at one of our meetings, which was, I never do anything always. And that seems very appropriate for this, where, you're really having to adjust to the location of the tumor, the biology of the tumor, the nature of the patient, the amount of soft tissue extent. So I tried to do a little bit of compare and contrast, whether to reconstruct, whether not to reconstruct. I don't think it makes sense to be dogmatic in any of these. You really kind of follow the patient and follow the tumor to what makes most sense. There's always reasons to and reasons not to. And I think that's part of the joy of this work, is working through it. And obviously hearing from other people who are doing a lot of it is a very helpful way of informing our practice. I chose two pretty similar cases to work through some of the nuances. So I have two periacetabular chondrosarcoma cases, looking at kind of how does the tumor and location extent impact our design, whether or how to reconstruct the ring. I think one thing that people have alluded to is, if you're only taking away a very small amount of obturator ring and you're preserving most of the posterior column, maybe that's a time to reconstruct. If you have a huge void and there's not much to attach to, maybe that's a time not to. I think, if we talk about the literature of soft tissue reconstruction and symptomatic pelvic contents herniation, that might be another reason where if you're close, it might be worth doing. If you're very far, probably not. Whether to include sacral fixation. I didn't see that in either of the other two cases, and I'll point out where I use that. And then also just what approach to use based on where your tumor is. We'll see that the extended iliofemoral and direct lateral approaches have been discussed so far. I've predominantly used a modified Olliers or a question mark or Henry approach, and thinking about how to use those for a type 2 and a type 1-2. Obviously, if you're beyond that, anteriorly or posteriorly, a more extensile approach. For me, all of these are done in the lateral position, in a sloppy lateral, because you need access to front and back. Obviously, the type 3s would be more anterior for me. So the first case is a 39-year-old male with hip pain that came on while he was training for a marathon. So it was just mid-marathon training. Everyone may have hip pain with that. His obviously looked like bowel gas to someone on the plain x-ray, but as we got advanced imaging, it was clearly not. So this was biopsied, found to be a grade 2 chondrosarcoma. To spare everyone from having to scroll through multiple MRIs to understand these tumors, I've provided these 3Ds that come to us in our segmentation. So this one notably is really contained in the periacetabular bone with minimal soft tissue extent. Stays out of the ischium, above the ischial spine, and not in the anterior ramus. Our other patient is a 55-year-old female with several months of increasing hip pain, has a periacetabular grade 2 chondrosarcoma. You notice that there is a bit more extension into the superior ramus with some soft tissue extension in the front. This is the segmentation of that, showing that soft tissue extent in the ramus, but again, staying away from the ischial spine. So a lot of this, the tumor guides you. And so I made this quick table just to show what's the same and what's different. Same histology. One is clearly type 1, one is type 1-3, or sorry, type 2 and type 2-3. One with some soft tissue extent. Both stay kindly away from the ischial spine. One, the whole acetabulum is involved. The other one, it is not. One, neither of them have the entire obturator ring involved. So even the one that includes the superior ramus stays away from the symphysis and avoids the inferior ischium. Both are young, healthy, active individuals with no significant medical comorbidities. One is a BMI of 24, one is a BMI of 36. So looking at what's the same, both of them are very centered around the acetabulum, staying low in the iliac wing. and both stay above the ischium. I think those are things that just frankly make things easier, but they're tumor dictated. Obviously, you have to be able to adjust, and if you have something bigger, you got to go for it and find a way to do it. But certainly anything that allows you to keep the sacrospinous and sacrotuberous ligaments intact is going to make your exposure and your resection much simpler. So for both of these, we have this kind of dome-shaped osteotomy. And Dr. Goulding mentioned a little bit that that's nice because it kind of keeps those force vectors within the line of weight bearing. I think another thing is it gives you a really nice point of congruity for your guides and for your implant. So you can really feel where that guide fits. It also gives you a nice wide column of bone at that gluteal pillar and a pretty nice wide column of bone at the posterior column to send big screws kind of in two directions into the gluteal pillar and into that thick bone towards the PSIS. So that's one component that's similar in these cases. It allows us for a pretty similar cut in the ilium. Another thing that's the same is we're going fairly posterior in the notch for both of these. And for me, once you're that posterior in the notch, you're pretty parallel to the sacrum. So you have this straight shot to put 90-degree, another angle of fixation into the sacrum. So I wouldn't call it a fixed angle construct because those aren't locking screws, but it's compression in a perpendicular axis, which to me is a helpful thing for how this is fixed to the bone. So both of them have a very close flange anyways. So you can see in this one, we only went a little bit further posterior with the flange to get a fixed angle construct with good compression and a long screw. Those I'll tend to do on fluoro. Certainly you could use CT guidance and navigation, but I tend to do that with just inlet and outlet views on fluoroscopy. So what's different? This case, again, stays above the ischial spine, but does not involve the entire acetabulum. So similar to Dr. Lynn's case, did an intra-articular resection, allowing us to do a ream in the inferior acetabulum. I think part of that, it makes it much simpler to reconstruct the ring because you've really kept that intact. You've only, you have one cut above, one cut below. Your obturator ring piece is in continuity. It's one piece. It's much simpler to reconstruct that. Again, not that it's necessary, but there's just a lot more congruity for fixation. Whereas in this case, it involves the entire acetabulum, so it's a more quote extra articular restriction of that. I think looking at Dr. Lynn's case, how inferior he had to go for that cut, man, that is a struggle, especially using the exposures that I do with the question mark and the modified Olliers, getting down below that infracotyloid notch and that fossa gets really tough. There are points for congruity for those guides. I tend to get both the detached and the connected handle guides for each case, in part because you can use the connected to help verify, see where you are, even if you're not going to use it for your final placement. But through both of the approaches that I tend to use, trying to maintain soft tissue congruity, it can be really tough to get those inferior ischial guides. Another thing that is different, this one involves the superior ramus, but I was able to keep a little bit of the inferior symphysis attached. So that was something where I felt like because we were that close, we were able to save the ring. So another piece that's different is the involvement of the superior ramus. That was pretty different for one versus the other, which helps to me dictate what approach you use. You can see for both of these, I did a reconstruct the ring. Again, that's not something I do dogmatically, but if I'm very close, I'm not taking as much. I'd argue that this one is pushing it a little bit. How I do that reconstruction involves these suture cerclages, so thick suture fiber with a compression tightening device to make sure that that is very tight. So when I reconstruct that symphysis, I'm not just leaving it. There's these fiber cerclages going around the symphysis as well as around the implant to that bone. In my mind, if something like if you don't fix a syndesmosis with screws all the time, we have a synchondrosis here, so I'm doing something that has some motion built in. Other big difference is whether there's soft tissue extension. In this case, there's none. In this case, there is some, and it's anterior. That tells me that I'm going to need an approach that gives me good exposure of the vessels. I need to be able to dissect into that retropubic space. I need to be able to take a rim of obturator internus as margin. So I'm going to have to be way over medial. So this is a paper that I found helpful in guiding what I do with those two approaches. So anything that is strictly type 2, that question mark where I'm keeping all the abductors on and working back, dislocating the hip anteriorly. You can either work on the inner table or not. You can stay entirely out of it. You don't even need to expose the vessels with that. Whereas if you have to come more medial, then you're going to need that modified olease where you can extend along basically a Van and Steel incision that then arcs up and over. So you have wide open exposure of the vessels. But then with the trochanteric osteotomy, you can get all the way to the posterior aspect of the notch as well. There are not a lot of good descriptions of these exposures. I think that is definitely something that it would be nice if some of us could put together good diagrams, good surgical pictures. There's really nothing. A lot of what we have in literature is borrowed from trauma. But that's a cadaver lab exposure of that modified olease that goes all the way over. So the final x-rays for this patient is our 39-year-old male. He is more than a year out. So because this is purely type 2, question mark approach for me, keeps the abductor origin entirely on, goes back on quite easily, saving abductor function. No need for a trochanteric osteotomy, which especially in the setting of someone who's going to need chemotherapy, I worry about that more. For these chondrosarcomas, I worry about it a little bit less. Anytime you can save the inferior acetabulum and the way it's safe from the sciatic notch certainly makes the exposure and the resection easier. And if you have a flange that's going pretty far posteriorly anyways, considering that screw going medial crossing the sacrum. Another thing I learned from this patient is these patients can do incredibly well. I'm very glad to hear that you let your patients bike. This patient told me he was going to return to running. I found out partway through that he was training for the same half Ironman triathlon as I was. And so we did it together. He finished 30 minutes behind me, but he beat me on the swim and the bike. So this is the last patient. So final images, because this was type 2, type 3, had to come more medial, so used a modified olease approach, and used a kind of unique construct for the ring with those screws going down into the ischium with a fiber tape cerclage around that piece of bone, additionally backing up the screws, as well as fiber tape cerclage across the symphysis. Thank you.
Thank you very much, Dr. Roberts. It's great to see all of these patients with these amazing functional outcomes. It's really inspiring and an exciting field to be in, definitely. We did have some questions here in the chat. And for the other panelists, do you use sacral screws? And if so, under what circumstances? You were saying that when you have a very posterior cut and posterior column and you can get that flange spread posterior, you have a great angle for 90-degree screws. What is the experience amongst our other panelists?
I have not used the screws or have had occasion to do that, although I'm kind of curious to see if I can find a case to give it a try.
I think one thing I'd comment on that is you have to be mindful of your order of reduction for those, because if those make it rock posteriorly because you suck it down. So I'm always careful to first reduce to that apex with my PSIS screws and my gluteopillar screws to suck it up. Then I'll bring the other screws down because the order of operations matters because that main piece fitting in is super important. Then if I am going to reconstruct, I'm reducing anything else to the implant. So up to the apex, down to the back, then anything in the ischium.
I have not had occasion to use it either. I designed an implant for this complex spinopelvic case in a hemipelvectomy, hemisacrectomy, and then And then I got cold feet and didn't use it. So just did like a regular spinal pelvic fixation. So I haven't had occasion to use it either, but I like the concept of the sort of the 90-degree angle. I think I would worry about, loosening and what happens to those screws if they cut out or something, of that nature. But I like the concept in theory.
And just a reminder to any of the participants who joined us later, please feel free to put more questions in the chat. They're coming in now, but we're getting close to the point where we're opening it up for any questions whatsoever. So we have another question from the chat here. How do you get the exposure for those cuts without a trochanteric osteotomy? Are you using Coker-Langenbeck to do that?
I guess let's see. So for the ones where I'm not doing a trochanteric osteotomy, I'm using a question mark. So that's coming along the iliac wing, coming down and through an anterior interval, going over on the skin. Skin comes back to avoid the apex, but then it's through the anterior interval where I'm bringing sartorius rectus, taking those down, dislocating the hip anteriorly so that you can get across. I will always try to preserve TFL distally, but that's kind of a bit of a jailbreak. If you need it, you can just come across TFL. Always try to keep it intact. And so that's where the question mark is limited in how far back you can get. You can get to the back of the notch, but getting inferiorly is a struggle. If you have to go below the ischial spine, it's really hard. That's an extent. It really is lovely to keep those soft tissues intact. But it's pushing the limit to get inferior to the infracotyloid groove.
Dr. Lynn, when you're making that posterior cut with the bone scalpel that you mentioned, have you had any issues with fitting the implant in? Because sometimes that visualization is difficult around the cutting jig around the ischium. Have you found that there's good implant apposition in that area when you use the bone scalpel?
Are you asking about above the acetabulum or at the ischium?
At the ischium.
Well, I more times than not did not try to connect to the ischium, only in more favorable instances when I'm pretty confident that the cut's going to be very accurate and it's going to wedge right in there. But if I'm not sure about that, I'd rather not. The risks there, one is the nerve can get caught if that junction is not perfect between implant and bone, and people can have pain there too. So I guess the answer to your question is more times than not, I chicken out.
Fully understand that.
We had an additional question to the chat about what size sacral screws are typically used. I guess, Dr. Roberts, what size do you prefer?
Those are usually like 6570 cannulated screws is what I've been doing. Is that way I can do it over a guide wire. So those make the design a little bit more complex, but it also gives you some freedom because you can choose the length. You can use a guide wire, do it under, again, fluoro or navigation. It'd be hard for me to trust navigation. I would probably want to check that on fluoro anyhow. So that's why I think it's important to be comfortable with SI and transiliac transsacral screws under fluoroscopy, which doing those in the lateral position I thought would be more challenging, but I've actually had decent experience with it for these cases and getting the imaging.
And for the group, one question that came up was designing the margins. So Dr. Goulding, you mentioned 8 millimeters. Some people say 1 centimeter. And of course, that takes into account the tumor biology and growth potential. But what are your thoughts on margin status and how to account for that or tell other surgeons how they should design maybe the margin of error?
I think 1 centimeter is a good, is a good target. I think if you're really trying to save bone in a very critical area to say, prevent you from having to make a third planar osteotomy or something like that, then I would go bigger. I think it depends really how much bone is left as well. I'm not comfortable getting any closer than 8, and I have yet to have a positive margin using a guide actually. So I've been really pleased with that.
I think your point there that it's histology specific is important, and I think there's even more than that. It's what is the growth trajectory that you've already established, and what treatments is someone going to get? So the two that I presented, right, are chondrosarcomas, grade 2 chondrosarcomas. So they're not getting neoadjuvant therapy. You generally speaking are not going to expect them to grow rapidly. But for me, if you have something like a Ewing sarcoma that's had a kind of big run in and their response to chemo, should be good, but what if it's not? I worry a lot more if you have that rapid growth trajectory that you're going to run into trouble depending on your response to chemo. So those are the ones where I would get a lot more nervous. Is if you have seen rapid growth and you don't know how it's going to respond over neoadjuvant, I'd be a lot more hesitant. I'd probably make a plan for the best and know that you can bail if the implant doesn't seem like it's going to cut it. Because obviously, I think that's the nightmare scenario is if you get imaging as you're getting into the surgery that shows that your guide is going to lead you to a positive margin, you have to talk with the patient and have a bailout option.
I like that idea of the trajectory of growth because typically we will have sequential imaging and thinking about what treatments have been tried. So that's a nice nuance besides just the biology itself.
Yeah, which you may not always have.
Hopefully we'll get the metal printing down to 2 weeks, right, Chris? And then it won't be an issue.
Absolutely.
I'm sure it will get faster. So we're reaching the end of our time here. So just some summary points. I think I never do anything always. That you brought up Dr. Roberts' quote from Dr. Raskin is pretty indicative of what you have all echoed, that you need flexibility when designing for these cases as well as when performing them in the operating room. There are a lot of intraoperative considerations that can be different, and it sounds like you design that into your cutting guides, whether that be uncaptured jigs or multiple registration points for your implants, those lower profile guides, and the step cuts, just any way that you can to try and design and have a little bit of flexibility to make freehand cuts if you need to. And then I don't know if any of you have a particular time that was a challenge to either get an implant reduced to your final bone resection, or any other last thoughts about things that have made it easier for you to take what seems like an ideal implant after you've engineered it and have it be functional in the operating room. It sounds like there's certain columns of foam that are also more successful, and thinking about those things, staying away from some of the danger areas that you mentioned are difficult to expose areas to be successful here. But any last thoughts of wisdom or advice for our MSTS members?
One of the things that I thought as you were bringing up was the actual saw blade. And so you want a saw blade that is rigid enough, but not too rigid. And then you also have to be aware that as you're making that cut, you can deflect up, which can bring you actually closer into your margin. So you need to be extremely mindful that you are right on your guide when you're cutting. And I've had one case where I was placing an allograft into a pelvis in a small kind of more geometric resection where it was a major issue. And so I'm very careful about what blade I'm selecting for what purpose. And I also use an uncaptured guide because I feel like I need to be able to stare at it as I'm doing it to make sure that it doesn't get deflected and, and compromise the margin.
What size saw blades do you gravitate towards at this point?
It depends. Usually like a 1.6, but it depends on the situation. Sometimes I'll even use a microsagittal saw.
Yeah. I like having a bouquet of saws.
Yeah.
Wonderful.
I might add one small point to your question, Megan, which is that you can't always have the perfect cuts every time in surgery. But what I found is that these porous ingrowth surfaces, and this kind of is reinforced by the other presenters here, the bone seems to grow and stick to them really well. and having that bit of confidence, if the implant doesn't go in perfectly, I would have a pretty low threshold for putting in a constrained liner, and knock on wood, that's not been bad. So there's some forgiveness there, I think.
I think that's a great point. That was one of the other questions that I had, is when to take that step to a constrained liner. So having that as an available for yourself, I think gives you that extra flexibility. Well, we are at 7:05, so 5 minutes over. Just to be respectful of everyone's time, I'd like to close the webinar. I'd like to heartily thank our panelists. Thank you very much, Dr. Lin, Dr. Goulding, and Dr. Roberts. This has been a pleasure to work with you all and hear different inputs, as well as kind of a summary of how you approach these difficult cases. I'd like to thank our engineering team as well, who have worked very tirelessly over multiple sessions to share this information and kind of show to our surgeons how these engineering calls can be. And just honestly, I learned a lot, especially about the thickness map and designing where the bone corridors are. So this has been very educational for myself, and I'm sure many other people. So again, thank you all so much for joining us for this webinar. It will be available on the MSTS website under webinars, so you can refer to that. If there are any additional questions, please reach out to the MSTS or myself, and we can get any additional questions answered from our panelists. And thank you all very much for your time, and I hope you have a wonderful Wednesday evening. Thanks for joining us.
Thank you.
Thank
Thanks
you,
for
Dr.
putting this
Shu.
on.
Thank you.